So in this refractive cataract panel discussion, we'll be having a very specific 7 questions that we'll be asking all the panelists. Like all of us know, now cataract surgery is no longer a rehabilitative surgery, but it has become a refractive surgery where the patient needs have evolved over the years. And now patient wants good vision without glasses for both near, intermediate and distance. And now, depending upon this point, I think we'll have the discussion. This. Anybody else who is there? Lohit, I request, please Rohit come out to the dais. I request Mathur sir to give a memento to Lohit from Retina. He missed the memento. One, please. Please. Sir, request Ajay sir also to please come out to the dais for the refractive cataract surgery. Sorry. Right. So, coming to the help. Right. Please provide the mics for all the participants so that we'll take one question at a time first. Sir. Yeah. So first question is, do you think there is a role for ocular surface optimization before taking up for a cataract surgery? How routinely do you practice this in your day-to-day practice? Do you look for the ocular surface, whether it is stable or not in all the cataract surgeries that you do, or at least for the cataract surgeries that you're going to put a EDOF lens or a toric lens? So, whoever is willing to contribute can start off. Mike.
I request the mainly audience, please raise the questions or any doubts. Because
on the relevant question, yeah. It's more of an open discussion forum.
Open discussion for the audience. And especially these two topics are very burning topics. A lot of advancements. Some people are extensively using, some people are at the doorsteps, and a lot of noise from the industry.
Correct.
That is the main part. So now the experts like the panel here should give a clear-cut message.
Yeah.
Is it a real technology worth using it or investing it? Then what is their practical experience?
Yeah. Mike. Sir, otherwise, you come.
The first question is related to the biometry, optical biometry.
Not about the question, just a comment to start the discussion.
Yes.
In one of the CMEs last year, which I attended, one of the questions I asked, because I was using only about 10%, 20% of these multifocal lens, I was asking one of in the panel, so what is the indication for multifocal lens? So one of the young doctors said, if anybody above 40. So the future trend is going to be like that.
Correct.
So there are a lot of people demanding for lifestyle issues. They come and ask, they ask for LASIK, but they mean that it's refractive lens exchange.
Refractive lens exchange.
So that demand is going to increase. All of us will face this. It's an important topic. And how to deal with it ethically. And some of your colleagues have advised for 6 cataracts, and then you wonder where you are. So I think all of us have to face this situation, and this is an important debate. I think all of us should participate.
No, coming back to that question, optimization, there is no doubt that you have to optimize before, actually performing all your fancy tests. You are buying such expensive machines, and then you get a wrong reading. It does not make sense. And as Madhukar said, it's not your counseling, everybody else is counseling around you before they come to you. So patients' expectations are very unrealistic at times, extremely. So at least you got to show that you are trying your best. You may not always hit the jackpot, but you have to get somewhere near there. And optimization, I think, is essential, but extremely difficult. In a place where I practice, I can talk like this. I never do it.
Correct.
I'm never going to do it. But in the city, when you are promising all these things, you have to do it.
Srini sir.
Optimization of the surface, 2 things here. Before the biometry, the biometry K reading should be done on a virgin eye. You see the patient dilated and then decide for cataract surgery and for biometry. You're going to not get the perfect results. If you have decided for the cataract surgery, you have to call back the patient on another day and do it. Regarding optimizing the surface before cataract surgery, it's really important before you advise multifocals. And even the major trend now is probably because of many reasons, the percentage of multifocal implants all over the world has come down because these EDOFs and all have come in. But even for that, the surface should be okay before you do the cataract surgery treat. Especially important is to look for the meibomian gland dysfunction. You see a perfectly okay patient, then post-cataract surgery, you'll see all those, that bubbles on the margin and all. So I make sure that that part is absolutely okay. I give them, see, I was giving doxycycline recently. Many patients, at least in my area, are developing GI issues. So I've shifted to azithromycin. I give it 1 gram a day for 3 days. Treat with ointments and medications. And if the patient has a frank dry eye, cyclosporin drops really helps. No financial interest, but the Sequa, and I've had many patients been rejected from elsewhere because of severe dry eye. Put the patient on cyclosporin, and my patient was absolutely fine postoperatively. So optimizing the surface is extremely important, especially if you're going for EDOFs, multifocals, or enhanced monofocals also.
Monofocals.
Yeah.
Meher?
You were talking about dry eye, no?
Yeah.
He was talking. Would you actually do a multifocal in a dry eye?
Yeah,
And
in
the
a
other
dry
thing,
eye-
the other thing I want to know,
Yeah.
the multifocal is a problem, diffractive, refractive. You
In
may not have a
estab-
dry eye now. You may have a dry eye in 10
An
years.
established case of dry eye, definitely will discourage them.
Avoid.
The best we would go for is an advanced monofocal. Whatever cases we are discussing is, these are all near normal patients. They look
Yeah.
normal before, and they cross a threshold post-surgery, and then they start to show these signs of ocular discomfort. So these are all the cases that we have missed pre-op.
And I just want to raise a point and
Yeah.
just for the, see, now patient is normal. You implanted a multifocal. What about the future? What if he develops a dry eye? Are
Sunil,
you going to
that
explant
was,
it?
Yeah, that was a very good question. This question way back we started when the multifocal was introduced. Do you do multifocal in a case of diabetic? So, if if they develop a maculopathy, what will be the situation? I think with the evolution of the design, now we are in a better position. We are not going to do any harm at least
Yeah.
in future, especially with the different models of the technology of the multifocal and the EDOF. In future, if they develop dry eye, I don't think for that reason we should not avoid the multifocal. That's my opinion.
Meher?
Sir, Meher.
Correct.
Yes. Here everyone is like. No. See, here everyone is new.
Everyone is,
Yes,
yeah.
the
We
technology
are all
is like
students
that.
here. Meher, please.
No, I agree with what Srini sir said, but one thing which we have noticed personally at our institute is there were many patients who couldn't undergo cataract surgery due to COVID. There was a 2 years gap.
Correct.
Where patients were they wanted to undergo surgery pre-COVID, but they turned up after 1.5, 2 years. See, we noticed a lot of difference in the K values of the patients while we are doing, we are repeating the IOL master.
When you repeated it.
When we repeated it post-COVID. So a lot of this patient develops dry eyes.
Because of digital screen
So it is-
usage during
after
COVID.
that, what we started doing is we started testing Schirmers for each and every patient who are undergoing premium lenses at least, so that we can diagnose preoperatively, dry eyes preoperatively, and avoid probably some expensive lenses, or first treat the disease first and then go for surgery.
Correct, correct. Ajay sir, anything you want?
Basically, we need to look at the lid structures and all. What I mean to say, what sir says, meibomian gland dysfunction is the main thing. And people suffering from computer vision syndrome, proper counseling has to be done, who are really working 6 to 8 hours or IT sectors. Those people clearly need to be counseled before doing. And a proper refraction has to be done.
Yeah.
Calculation part, it may differ depending on the bias and all.
Yeah.
But lead pathology has to be ruled out before doing any cataract surgeries. That's my take.
Thank you. Balu, you want to add something? Yeah. So I think to sum it up, I think ocular surface evaluation and optimization is very important, especially when you want to have a good refractive outcome. And when you diagnose something preoperative, I keep telling this more and more often, whenever you diagnose something before the surgery, it is patient's problem. And if it turns up after the surgery, how much ever you try to convince, he'll think it is this surgical complication. So always try to do a very thorough investigations before your surgery. And in these cases, unlike dry eyes, I think we have to be vigorous in the treatment. So here I think cyclosporin and other anti-inflammatory along with lubricants, all these things play a role. Usually in 2-3 weeks when you do this rigorous treatment, the ocular surface stabilizes, and after 1 month you can repeat your K values and biometry and then take it up for surgery. Sir, you want to add some?
Yeah, along with the comprehensive examination, we have to include the ocular surface as part of your
OSDI, correct.
And
Meher was telling
simultaneously,
Schrimmers, actually
yeah.
Schrimmers is also good, but if you can do tear breakup time, that's even more specific, because Schrimmers sometimes it can be subjective and it is dependent on many factors. That simple tear breakup time with your fluorescein is also good enough. With an ocular surface questionnaire also is good.
And also simultaneously, please document in your case.
Exactly. So now we'll go to the second question. Regular biometry, there is no doubt. Now with the new generation biometers, I think we get bang on refractions. The problem comes with the eyes that are extreme. So let us discuss about 3 conditions. One is very short eyes, very long eyes, and post-refractive surgery, that is post-LASIK eyes. So these 3, so let us start off with short eyes. Your preferred biometry options or IOL, like whatever formula do you change, or in your experience, which works better? We'll start off with you again, sir. Madhukar Reddy, sir.
I normally do Barrett's, that's a common thing, this one. Otherwise, I follow that in general. I don't change
Nothing special for
nothing
the very
special,
short
unless
eye.
if it's too, I don't advise in high myopes or high hypermetropes, I don't advise a multifocal lens.
lens. Sir, any special formula that you follow or?
See, if you look at the literature, they say Hoffer Q, but actually when they evaluated, the SRKT was good enough.
Okay.
So I just go by that.
Sir?
I go by
The
Barrett
regular
2K.
Barrett 2K.
2K.
Standard
It works.
Standard protocols.
Barrett?
SRK.
SRK, okay. Any specific reason why do you go for
Good results.
good results? You are in experience.
Yes.
Yeah. Meher?
Barrett's.
Barrett's, okay. Sir, Ajay sir?
Mine also Barrett's.
Barrett. Sir, your experience?
See, no doubt SRK is a time-tested and then the well-established formulae.
Yeah.
So, but if you see the advancements in the biometers, like recent Argos and then the IOL Master 700, so the prediction errors are very, very less. Earlier SRK T or the SRK2 and all, the parameters which were considered in the calculation were limited. Whereas in Barrett's and all the recent generation, the biometers, where they take the posterior corneal astigmatism also into consideration. Especially Argos, the segmental
OCT is
index, refractive index.
yes, segmental
Like
axial length we get it there.
Axial length we can get. So these are maybe looks simple and
But
then
it
the
makes a
minor,
lot of difference.
but they makes a lot of difference,
difference.
especially in the prediction error.
Yeah.
Our results, what we have personally seen is drastically improved with the
Newer
involvement
generation,
of newer
IOL
generation,
Argos
masters,
and
then formula is now
part and parcel of the,
that.
correct.
So may I add, like,
Yeah.
see, I've been believing IOL Master 700 only.
Sir.
So when I started my hospital, 2 months back only, so that is one thing that I really wanted. But the issue with me was that I have not got that permanent electricity connection, and whatever connection that is happening is a lot
Makeshift.
of fluctuation. It's been lying with me for such a long time that, and they are not ready to install it because. So now the surgeries I'm doing are with immersion and SRK by T. I am getting absolutely perfect results. So SRK T
Barrett's, yeah.
I think we are deviating from the short eyes to long eyes and then the post-refractive.
Yeah.
Definitely measuring the posterior corneal astigmatism like in post-RK cases,
Yeah.
measuring exactly the central 0.9 mm of the corneal keratometry value. These things may not be possible with the
regular things, yeah. Because here you have
immersion technique
inbuilt
and
4-cut
other
RK, 8-cut RK, 12-cut
Yeah,
RK that are
yes.
already included into the formulae so that
Yes.
you need not
Yeah.
put much of your things.
See, we agree with all your 90% of the cases beyond these
Correct,
variable
correct.
cases. In
Yeah.
those cases, it's okay.
Yeah.
But the post-refractive, post-RK,
Yeah.
the
And
high
I think-
myopia.
And one more advantage, like, I mean, the question might come, optical biometer, and is there a question there?
No, you can still
So the one advantage that you have with an optical biometer and is that you don't need a well-trained person to do it.
Correct.
Yeah.
So that is a
Less
huge advantage
Yeah,
that
human
you have
element
with
of
an
error.
optical
Yeah, human
biometer.
technical
Yeah.
error.
Absolutely.
The human error is taken care. And just one more point relating to this I would add is in short eyes, apart from this formula that we all totally agree, I think I don't allow the cataract to mature more because you're going to work in a very short space. So I usually suggest an early cataract in these cases so that you can have more control over the surgery rather than making it into a brown cataract and making the cornea more prone to the burns. So that is one point I think it's important that you take up early in this short eyes cataract surgery.
I mean, which are those patients that you are going to select? Those high hypermetropes or so how do you, the patient comes to you with
Usually-
minimal cataract and you...
No, like I usually tell them about 24 diopters, plus 24 diopters if I get an IOL.
No, that is if you are have
The short eye.
at least little bit of cataract, right?
Yeah, little bit.
Yeah,
of-
there
correct.
should be a little bit of cataract.
not clear. Yeah.
Yeah.
Short, when you say short, is a very broad perspective. Suppose it's towards nanophthalmos or
No, these are regular shot. Correct.
plus 10. What do? You don't wait for a cat.
At least you wait till the age of 45, I think. You have to wait till the age of 45 is, I think, is a safer age to go in for a refractive lens exchange. Before that, we don't usually do it. So next, coming to myopia. Myopia and what is the role? Suppose somebody is using an IOP controlled phacoemulsion. Do you think it really makes a difference in myopia? Myopia cases where you see a lot of fluctuation in the anterior chamber. And do you think that having a controlled IOP will give you better outcomes and better results? Sir, starting from you again.
I use the Legion machine now, but I don't have that pressured
It's
this one.
gravity.
Yeah, but in high myopes, the whole thing goes down,
Yeah.
and then I decrease my bottle
Bottle
height
down.
and gently do it, and most of the times it's okay. I mean,
It's
you
okay.
really don't face trouble
much
as long
of a
as you are
difference.
doing it mindfully.
Correct.
So you don't really have
the
to
question
have
is
a-
mainly versus the active fluidics versus the
Correct.
gravity control.
Yeah.
So maybe, I think gravity control, we may be manually adjusting it more frequently, whereas in the active fluidics, so there are a lot of options where automatically the correction can happen and then give slightly better comfort than the gravity.
I understand, but we don't make that decision while making the machine.
Yes, correct.
Yeah, it's basically a surgical technique to prevent that pupillary,
Correct.
reverse pupillary
Yes,
block
sir,
from
yes,
happening, and you make sure that
Yeah,
that goes.
one small tip we see from Haripriya ma'am's videos, She just gently pushes some
No, just push
fluid
the iris.
under
Yeah,
the
under the
iris,
iris.
so that it
Panel, yeah.
has a very good practical tip that she gives in all her high myop
The
surgeries.
problem with these high myopes is sometimes they give a
Ah,
jerk.
exactly.
They give a jerk when this happens.
And
So
you're
those
operating in a
things-
well kind of a thing.
Yeah.
The main thing what I want to tell the audience is don't get confused about active fluidics and gravity. Both are fine. I mean, it's your surgery. And don't worry about the reverse pupillary block. In fact, you can use the reverse pupillary block to your advantage. Put it up, let it dilate, you can happily handle it. The problem with myopes that you get is operating too deep. You don't know, sometimes you feel you're inside the vitreous cavity. So that is the problem. So you have to be, and always bring down your bottle height. There's no doubt about that.
Meher, myopia, any special formulae that you follow, or the regular Barrett's or the IOL master you just follow?
Barrett's.
Barrett's again. Ajay sir, any special care in myopia cases?
I think the only problem in myopia, what I feel is do a proper axial length.
Correct.
Because we don't know exactly, if they don't have machines and all.
Yeah.
Posterior cephaloma, people are not aware.
Correct.
So you may get different, like bias will come where you send. So
it's always
before doing
ideal to
any
do
IOL
both,
yes.
both
Yeah,
eyes,
you have
so
to-
that
correct.
you know which staphyloma you
So
can pick.
that is a thing people should be aware of when putting, doing on myopia. Surgical part, what sir is, it depends on how comfort you are, whatever machines you have.
Definitely, I think gravity, we can still do it, there's no doubt about it. But once you get habituated, like I and Gopalraju sir, both of us use active fluidics. And for myopes, pseudo-exfoliation cases, pre-existing glaucomas, you can go as low as 24. You can just keep it in the physiological IOP. It may take 2-3 minutes more to get your cataract eaten, but it's very safe. There is no chatter. There is no fluctuation. It's as if you are operating in a natural eye, because the IOP is continuously maintained between 24 to 28. Usually we go till 28 while we are chopping, and once you are eating pieces, you can go as low as 24 also. That has been my experience, sir. Yes, sir. Yours also.
Yeah. Another question in high myopia is, earlier used to cut off less than 15, no multifocal.
Yeah.
IOL of less than 15. But now even 10, 9, people are insisting on it, and the companies also have come out with the even 10 and 9 also multifocal. But I've done few cases, they were fairly doing well.
Correct.
So maybe the opinion of the others.
Yeah, high myopes are reasonably happy even with multifocals,
Yeah.
but maybe with EDOFs, maybe we should work toward EDOF.
Correct.
That gives you, it's more forgiving.
Yeah.
And the second issue is always tell the patient beforehand that they can be a surprise and be
Yeah.
prepared.
Right.
Because
Correct.
once their expectation increases, they'll feel disappointed.
Sir, in
So
one,
decrease the patient's expectations first.
sir,
Here, the
before-
role of biometer is important, because our confidence levels have increased because of the biometry outcomes.
And I always undercorrect. I leave them minus. They're always, I don't know. Do
How
you
much?
know that?
How much, sir? Next negative, or you go more?
Sometimes even more. If they are very high myopes, I can even leave
Point,
them to minus.
0.75 and beyond.
Go even -1, -2.
Okay.
Because they are comfortable with that.
Correct.
Yes.
Meher.
doing a pan-retinal photocoagulation in a multifocal lens IOL is much easier than performing a barrage laser in a patient with multifocal IOL.
Okay.
So we have to be doubly sure that there are no peripheral tears or something in
Beforehand.
a high myope patient,
And then
plan on it.
do it. And the last,
Meher is the ideal person for
correct.
that.
The last one is post-refractive surgery. Now, because in future, I think we'll be having at least 50% of the cases that would have undergone some kind of refractive surgery. So again, any preferred techniques, sir? Or, preferred IOL calculation?
ASCRS, that
ASCRS
calculator.
online formula?
Yeah, that should be.
All of you, same thing? ASCRS online formula? Okay, right. Sir, please.
On-table refraction.
Sir,
And
that
give
is
the correction.
you're telling about the machine?
Aura.
No.
Not aura.
No. Do a refraction,
Oh, okay.
retinoscopy, and have this thing, so that you double check.
Double check it.
Double
Oh,
check whatever is.
Yeah.
Yeah, that
Logistically,
is,
that is
when,
also difficult. You don't
can-
have a
can-
library.
No, you can at least not
No.
implant.
Correct.
Not implant. No, no, no.
So the third point is now I think suddenly in the last 1 year we have a lot of femtosecond cataracts, femtosecond machines in Andhra. Meher has recently bought one. Akira sir, has been having it from the last 1 decade, sir. Yeah,
More
I
than
think
that.
more than 1 decade. I think one of the earliest adopter to femtosecond. And in today's scenario, how do you think like any there are I know there are some specific cases where it definitely has an advantage. I think if the users can throw light on those specific indications.
Yeah, specific indications. One is the total white cataract or intumescent cataract. Definitely the success of the capsular excess is much better. That's number one. Number two, patients having a moderate astigmatism, say like up to one cylinder. So where you can have an arcuate options. So where we may not push the toric lenses, so definitely that has got an advantage, but definitely it's not as predictable as the toric lenses, because arcuate incisions are almost a little under predictable. So these are the two special situations where definitely LensX has an advantage. Of course, the final and the most important is as a marketing point or the patient's point of view, they feel all these anxiety related patients, they feel if it is done by laser, it will be less painful, and they feel it's not surgery, it is laser. So like that, everyone imagines on their own perspective, and they will opt for the laser. So of course, we'll clear the myths in their brain, but definitely it has some value. So as a marketing point also, it
Something
has,
like
carries some
one-upmanship. I have it, they don't have it.
Yeah.
I
No,
mean, it's
the
definitely.
person who is not having it, I don't think it's not a big negative, but only thing is the circumstantial situation. If somebody is having around you, doing a lot of noise, then definitely it feels some discomfort with the patients when you are talking to it. So that was the situation.
Sir, like you have the option of arcuate,
Yeah.
or you can go for the opposite clear corneal incisions, which also give about
Some amount of
175,
flattening. Yeah.
So my question is, what is the stability of this thing? Is there a regression over time with
Arcuates.
yeah?
Yeah.
Have you seen that in your practice?
Yeah, definitely. I think that was a good question. The arcuate incisions are always unpredictable, and the long run, the stability is questionable. So that when we are doing only in a moderate myopia, less than 1 diopters, so even if it decays, it will be not more than 0.5. So still reasonably acceptable results with the arcuates and other things.
One question.
Yeah.
You have a patient for multifocal, have a 0.5 diopter astigmatism, and would you go for a multifocal with an arcuate in that?
No.
Practice management.
Anything less than 1 only. If it is multifocal, even we don't even take the chance, because the predictability is low when compared with the toric lenses.
Now you have T1
So,
and T2 lenses in
T1
toric.
and T2
so
lenses
instead of
also-
arcuate, they are more accurate.
With the toric lenses, they are more predictable. More
Predictable.
accurate
Yeah.
than the arcuate incisions.
That's what I'm telling. Previously, we didn't have that 0.75 and
Yeah.
No, I'm talking about 0.5.
0.5 you can just leave it.
I think we can go with an arcuate.
Arcuate or even you can leave
Or
it.
leave. Like, I mean, you have an option of
See,
arcuate.
again-
Will you go for it?
See, again, the economics comes here. So how much is your extra cost in a multifocal with toric option? Or how much is your extra cost for the LensX procedure or the laser procedure? So that you need to calculate. That patients also will assess before opting the choice. So definitely laser option will be more costlier than your toric lenses. Suppose he has not opted for the toric laser option, then toric lenses are much economical than the laser option.
Okay.
Oh,
So like this, there are a lot of
Meher?
complicating things.
You are one of the recent
No, I don't have much experience. I mean, as much experience as Gopal Raju sir. One more good indication for laser cataract surgery is patient with Fuchs.
Fuchs.
Definitely, there will be less collateral damage in
because
such
you are going
patients, and you are
to
going to
pre-chop
preserve.
the nucleus.
Yes,
Yeah.
So
Sir?
any heart cataracts, I feel it really helps.
It helps.
Yeah, yes.
And then if money is not an issue, if the patient is willing to pay, everybody needs a good circular
no doubt.
central Rexis 5.1, that should be fine.
Yes.
But money is an issue. The once you raise the bar, their expectations also will keep increasing.
100%, correct.
So we need to really temper that and then see the patient's paying ability and then advise appropriately.
Gopal, you were talking about white cataracts as an indication. I thought there would be one more. I thought say an ectopia lentis or a subluxated lens, that's where you can have a big advantage of doing your
Yeah,
excess.
even dense PCC also, some
Yeah.
centers are opting.
Posterior nodal cataracts.
Yeah, posterior polar cataracts. And then the subluxated lens,
Even
or
very-
the traumatic subluxation, granular dialysis.
Very young patients also, where it's very difficult to do your Rexis. There also it has a good role.
And this controversy about flax and the regular phaco, if you actually look, there was a big study done by Schweitzer for the French government, because when France, they wanted to say, they actually asked whether they have to invest in femtosecond for the country, because it's all done free.
Public health.
And they had done an extensive study, and there was no difference between the
Yeah,
regular
all the major
phacoemulsification.
reviews and the
There
so
was no
far
difference at
published,
all.
Not much of it.
no significant difference.
No significant difference.
Even though the amount of ultrasound used is less,
Nothing.
some
Yeah.
amount of the time, everything is better, but it's not significant.
Yeah, I think in the interest of the time, we'll just take one more topic and then go for practice management session. Yeah, please. Mic, please, to Vishnu sir. The next topic would be managing post-operative
My
refractive
personal
surprises.
experience and for the benefit of those who are having femtomission, I underwent femtis lens, which is a capsule fixated lens. It's not capsule fixated. You can fix the lens to the capsule. So to do that, you need a certain amount of diameter, precise diameter.
And
My
that
lens
can
is
be done only by
3.9 diameters,
femto.
3.9 millimeters. So do that exactly to do that diameter, you need a femto.
Yeah,
It's a
Sri Ganesh.
I underwent it. So you need a 3.9 millimeter precise this.
Yes, see, for that matter, all multifocals, you need a well-centered, correctly, ideal size.
There is a margin of error is there.
Yeah,
Real
even,
lens
even
fixated,
that
it
kind
is,
of lenses, it's more advantageous.
Yeah, so let us go for the final question. That is, despite doing the best, sometimes you end up with a refractive surprise. So what would be your course of action? How do you want to do? You want to go and take out the lens exchange, or you want to do a surface ablation? And what is your threshold? What is the threshold of doing this?
Yeah, first talk to the patient whether they are really obsessed by that or not. If they are happy, some people are happy with -1, -0.5, whatever. So just leave them, talk them into it, ask them to come back after 3 months, tire the patient.
Correct.
So after 3 to 6 months, they are still insisting, then go for surface ablation. That's the easiest, I feel.
Easiest, which we need not again.
Most important is, if you have already assessed, if you assess it before the surgery, there are certain cases like post-RK, post-refractive surgery, you can get a refractor. I mean, there are very high chances.
Those are expected.
So, right in the beginning, please tell the patient, this is a one-way street. We are not going to come back and take out and do all sorts of things. You expect this.
Correct.
So, if you do that, of course, if you have already convinced the patient, everything
Because
will be
still
going
we
well.
don't have access to light adjustable lenses where
Yes.
you can go and change it later.
Exactly.
Maybe in future we'll get it. But sir, Srini sir, post-op refractive sir.
I've done lens exchanges.
How early do you do it, sir? Comfort, because sometimes it gets
See,
used to the.
sir, if it is a -1 and all,
We can
it's
wait.
okay.
Yeah,
If it goes to the plus side only,
correct.
you have an issue.
Correct.
they will complain. -1, you can tell them, okay, I have planned it this way. I mean, I planned for you
Monovision.
to read,
Monovision.
and I'll adjust. But if it goes to the plus side,
Yeah.
then, or if it is something more than 2 and all, I'll go very early. I mean, very early, especially for a hydro.
That too explaining to Kerala patients.
Not very easy, but
If you can
somehow-
do to your patient, I think all over the country you will be very successful.
One of those airport scanners
Yeah.
just scan before they
Because,
One option, I mean, just a comment. Piggyback lenses are a reasonably good option,
Yeah.
especially post RK. They are easy, just to slip it in, just do the calculation. I think
correct.
that's one.
Yeah, piggyback is a very good option.
Yeah,
that
rather
you have
than
told.
explantation.
Yeah, yeah. Explantation, it becomes difficult, sir. Sometimes we try to do it, haptic gets stuck. So there is no harm in leaving the haptic getting stuck and
Yeah.
just put the haptic in the other side. Don't be persistent to remove the haptic if it is stuck.
Astigmatism control also is another.
We can do. Balkrishna?
First thing, counseling.
Okay.
Second
Yeah.
thing, we have
Chair
to,
time.
Yeah. Second thing, we have to look for other eye status.
Correct.
If it is, then we decide about surface ablation or
Yeah.
other things.
Meher?
I agree with Madhukar Reddy, sir.
Yeah.
I think sometimes with high myo, you may get, like inadvertently, you can get powers and all, residual powers.
Yeah.
I think to take out lens and again put a lens or piggyback lens, if you are not confident enough, so
Correct.
better to go for surface ablation, but doing a proper refraction and orb scan and all. That's the safest procedure. If the patient is willing to spend, then you can do, or else you have to counsel them prior to that. So I think more than -1 or what sir said, plus side, those patients are little finicky. So they need 6 vision or six parts. So on those patients you can do.
There is a problem here with your center having a LASIK unit, refractive unit. So what do you do then? See, the patient has to go to another center. My question is,
Yes, yes.
you do you pay from your pocket or make the patient pay for?
No, any procedure post-op doesn't, I mean, patient doesn't pay. You have to do it.
No, if it is not there in your center, it's going to be done in another center.
Even then,
Oh, okay,
In
okay.
you have to use your good office and then manage.
That's what,
thank you.
first counseling, then you fall at the patient's feet.
Yeah.
Next, if you still can't do it, send it to
Yeah,
your
yeah.
friend. This is problem after that.
And get one done and refer 2-3
Correct.
surgeries to them.
Thank you so much. We are running short of time and I request all the panelists to come forward to receive the mementos. I request Senior Surgeon Krishnamurthy sir to please come out to the dais and felicitate all the expert panel. And I request the next panel to be ready for the panel discussion on practice management. I request Nandakishore sir and KV Apparao sir to come and chair this session along with Sriram sir, Gopal Raju sir to stay back, Dr. UV Raman Raju sir, Vishnuvardhan sir, Ramalinga Reddy garu if sir is available, Sharad Babu sir, Vijay Bhaskar Reddy, VTS Reddy, Kumar Swami garu, I don't see much of them here. Sandhya madam, I think you can join for the practice management session and give some tips also as you are available. Please, you are quite, you can give some tips to the jury. Please come on. So in the practice management, what we'll do is, because we are having less time, from each of the panel, we'll just take 3 good points for the youngsters so that they can implement in their practice when they go back home. From all the panelists, 3 points from their experience, what is relevant to today's scenario. I think in that way we can sum it up nicely. Thank you all, the expert panel, for your wonderful insights. I think it was very useful.